Hello, my name is Sharon Karlsberg. I'm a principal with ZS Associates and lead for our oncology marketing team at ZS. I'm here today at ASCO 2017 with Dr. Suzanne Topalian. Dr. Topalian is the Associate Director for the Johns Hopkins Bloomberg-Kimmel Institute for Cancer Immunotherapy. And as many of you know, the lead author for the seminal 2012 New England Journal of Medicine article that first detailed the benefits of checkpoint inhibition across multiple tumor types. Dr. Topalian, thank you so much for joining me today.
Thank you, Sharon.
At ASCO this year, we've heard multiple reports about tumor mutational burden, MSI high, certainly the microsatellite instability, the approval for pembrolizumab in those MSI high patients independent of disease area. Lots of different testing modalities for PD-L1 expression and different tests available commercially and within laboratories, and even cellular factors like the presence of tumor-infiltrating lymphocytes that may help us identify and select the right patients.
Yeah.
Based on everything you've seen at ASCO this year, what do you think are some of the most promising approaches to patient selection using these biomarkers that are available?
Well, so you mentioned two biomarkers that are general biomarkers across multiple cancer types. The one being the PD-L1 IHC test and the other one being MSI testing. The MSI testing, I think, is more straightforward if you compare those two tests. The PD-L1 test, well, there are several different tests that are commercialized now. They all use different protocols, different antibodies to stain tumor tissues for PD-L1 expression. They have different cutoffs for what is called a positive or negative tumor. They look at different cell types. Are we talking about PD-L1 on tumor cells or on infiltrating immune cells in the specimen? So that is a complex biomarker. I think it has been helpful in finding patients who are more likely to respond to anti-PD-1 or PD-L1 drugs, yet we do still see responses in the marker negative group, and so that marker has to be used with caution.
I would say one of your colleagues, Dr. Nair Rizvi, commented, we can use PD-L1 to enrich for patients who will be responsive to checkpoint inhibition, but we can't yet use it to select for patients. And so that's really, when a community practitioner says, what should I be doing to select the right patients who will differentially benefit from checkpoint inhibition or benefit from monotherapy versus combination therapy, what advice do you give them?
Well, so the MSI test, I mean, this is an example where that test can identify a small group of patients within a much larger population, the small group that will have a very high chance of responding to anti-PD-1. So you probably know a cancer like prostate cancer, maybe 2% of them are MSI high. Right. If we treated everybody with prostate cancer with anti-PD-1, that would not be a good approach. Right. But if you find those patients who are MSI high, their chance of responding to the drug is about 50%. It's substantial. Yes. And these are durable responses for patients who don't have other treatment options. So that's an example where I think we found something extremely useful to identify small subpopulations who are very likely to benefit. So hopefully all the effort that's going into research about cancer genetics and other intersections with immunotherapy will yield additional biomarkers that can be utilized in that way.
Okay. That's wonderful. Well, thank you, Dr. Topalian. Is there anything else that you think we should all be watching as we look to ASCO 2018 and think about the next generation of advances in cancer immunotherapy?
Well, I think, again, this intersection between immunotherapy and cancer genetics is a strong one. And I predict that we're going to see more examples of how those two approaches can be used in a synergistic way.